Hi again. I don't know how much when I was cut off, but my name is Julie, and I will be presenting on postpartum depression screening in Alberta between the years of 2012 to 2016. I completed my practicum on Treaty 6 territory, which is home to many diverse Indigenous groups. So the traditional territory of the Blackfoot, Cree, Dene, Nakota, Sioux, Saulteaux, and Métis Nations people. And my existence here is a privilege, and it was a privilege to be able to do my practicum here. I completed my practicum at Alberta Health Services and the provincial team for public population and Indigenous health, and then in the smaller group for program innovation and integration. Their goal is to kind of innovate and optimize programs for public population and Indigenous health throughout Alberta. And it was an amazing experience to learn about kind of how provincial public health functions. And a special thanks to my supervisor, Christina Loitz, who guided me through my practicum. And also for this project, Carol Sachkowski did the analysis at AHS. So I couldn't have done this project without her. I chose to do this project because it lends itself. I did a couple different projects with them, but this one lends it very well to a presentation. A culminating report. It's actually a paper that we're currently working on publishing. So I'm going to be going through the background and context, the methods, the results, the limitations, and then points for further discussion. So, postpartum depression, or PPD, is defined as a non-psychotic major depressive episode that begins at delivery and may extend into the postpartum period for up to a year. There is some debate on kind of the time period, but this is the definition that AHS uses, so it's the one that I'm using. Symptoms of PPD are consistent with standard depression symptoms. The only difference is the time of onset, and they include feelings of fatigue, excessive guilt, suicidal thoughts, appetite loss, or psychomotor disturbance. In addition, PPD can include negative maternal attitudes or poor parenting self-efficacy. So while specific symptoms need to be present in order to receive a formal diagnosis for PPD, a diagnosis isn't necessary to warrant interventions, and mild PPD symptoms have also been found to have negative effects. In Alberta, and in a lot of other places too, a questionnaire is used to screen for PPD. And the purpose of PPD screening is simply to identify mothers who aren't thriving in the postpartum period so that they can be supported further and symptoms don't worsen. So this is an important distinction because screening is not necessarily just simply for people to get a formal diagnosis for PPD and then get support, but it's a way to reach struggling mothers. If PPD symptoms are left untreated, they can lead to many negative health outcomes from both the mother and child. The mother can experience significant distress and difficulty doing everyday tasks and parenting tasks. And also, there's a possibility that PPD can disrupt maternal-infant bonding. Evidence has shown that this disruption can increase the child's long-term risk for several cognitive and developmental delays. In Canada, the prevalence of PPD is 10 to 16% of mothers, but as you can imagine, it's kind of difficult to get a real estimate when not everybody is screened and it is a stigmatized topic. And in addition, Canadian evidence has shown that PPD has been negatively associated with total household income, strength of social supports, if the mother has recently immigrated to Canada, and also maternal characteristics such as previous history of depression and anxiety. So for this study, in Alberta, the Edinburgh Postnatal Depression Scale is given to mothers at the first well-child clinic visit, which happens 2 months postpartum. So when the child gets first immunization. So it's an opportunistic but routine screening policy. So the mother is given the questionnaire, the Edinburgh Postnatal Depression Scale, on that first immunization visit. It is only validated for specific people, so it's not given to adoptive parents or parents who have given up their child for adoption, and it's not validated for other parents like fathers. It's a 10-item questionnaire that is usually self-administered, and then the score that you get is categorical. So if you get a score that's 10 and below, you're considered a mild risk for postpartum depression. If you get a score between 10 and 12, referrals are up to the discretion of the public health nurse, and you're considered a moderate risk. And then if you get a score of 13 plus, you're a high risk, and that always warrants a referral. So when this was done in these years, all that data was taken and it was put into a dashboard that showed who was and who was not screened. And if they weren't screened, why they weren't screened. It showed the EPDS score of those who were screened, whether or not they were referred, where they were referred, and whether or not they attended the referral. We only actually focused on the first part of that, because once you got to referrals and whether or not referrals were attended, it was a little bit trickier to follow that data. So then we took that data and it was combined with something called the Pamplon Deprivation Index, which is a tool to measure material and social deprivation. So it uses the censuses and the National Household Survey to measure social and material deprivation by postal code, because the health records also have a postal code, so you can easily merge the two to see what maternal characteristics were present. For the results, this first slide is to show what kind of numbers we're working with. So these numbers are from the total birth cohort in Alberta. It shows that each year around 32,000 mothers were screened, a little bit more most years. And that's the majority of mothers, so over 70% every year. And then one of the first things that we noticed was that for those that were not screened, the biggest reason that they were not screened was due to language and cultural barriers. So 50% of those not screened this year was due to language and cultural barriers, which kind of shows a big gap. And then this figure shows, so this was after the Pamplon Deprivation Index was merged with the data. So this is the percentage of women not screened by level of material deprivation. So as you can see on the right, you have the most deprived. So those mothers that were most deprived were the least likely to be screened. And then continuing from that, the most deprived mothers were most likely to receive an EPDS score of 13 plus. So just a reminder, a score of 13 plus is highest risk and always warrants a referral / intervention. Those were kind of the main findings that we decided to focus on for our paper. There were some challenges that came with this study. Within AHS, there are 5 zones: North, Central, North, South, Calgary, and Edmonton. AHS was actually only recently created in 2009 as a centralized authority to oversee Alberta, so there's a lot of work that's still being done to standardize policies. So a PPD screening policy was actually implemented in 2019, but prior to this, during this time, each zone actually had a slightly different policy. So there were some zone discrepancies with use of translated EPDS policy for reporting, potential alternative scales, etc. And there was also a difference in reporting software, which may have impacted the data. So each zone kind of used a different reporting software. So the main findings that we decided to focus on because of their implications to public health practice were that those that are materially deprived are less likely to be screened, but more likely to receive a score of 13 plus on the EPDS. This finding is significant because national and international evidence both show that socioeconomic status is one of the biggest predictors of PPD. It is important that we have policies in place where these populations are being reached. Those with language and cultural barriers are less likely to be screened as well. And this is another vulnerable population that we need to make sure our policies are reaching. So I just have some short recommendations, potential recommendations based on other studies that have been done. So for barriers for material deprivation can affect mother's ability to take time off work or can limit options for transportation and childcare. So some potential ways to intervene for those would be home visits from healthcare workers have shown to increase access to PPD screening, and then material supports for childcare and transportation, as well as material supports for PPD treatment for materially deprived mothers, so for things like counseling and support groups. And then other studies in Canada have also shown that immigrants to Canada are more likely to have higher scores and are less likely to be screened. So I associated those with the category of language and cultural barriers, although there's no way to link like immigration status to that. Other studies have found that multicultural health brokers can help bridge the gap for PPD screening and help those with language and cultural barriers navigate the healthcare system. They're also validated and translated tools of the EPDS that weren't used uniformly throughout the province. And then another recommendation is culturally appropriate support. So working with different communities to make sure that there are culturally appropriate supports that people can access, and that will likely look different for each community. But thank you so much for listening, and thank you. I want to say a special thank you to everyone, all the staff and profs, and Nigel, my practicum instructor, and my fellow PH peers. It's been a really great 2 years. And if anyone has any questions, I'm open to answer them.
Thank you so much, Julie. That was really interesting. I will, if you have a question, please press the hand button, and so I can see and call on you to ask a question. No. You're getting lots of wonderful comments. I don't know if you can see those, Julie, but lots of great encouraging comments from your colleagues in the MPH program. Oh, I think somebody. Oh, Annika, go ahead, Annika, with your question.
Thank you, Julie. That was an amazing presentation. Thank you so much. I was wondering. I noticed that the amount of screenings were decreasing between 2012 and 2016, like each year. So I was wondering if you found anything about why that was across Alberta.
So that was a big thing that we were. It took us a long time to kind of figure that out. So one of the reasons was that the screening used to be done not just at well child clinics, but it used to be done with, I think it was outreach nurses. And then they found that that wasn't an appropriate use. Like it wasn't validated for the outreach workers to be using it. I'm not 100% clear on the details, but that was one of the reasons that we thought that it might have been decreasing, is that they started kind of pushing for it to only be used in the well child clinic setting. But yeah, there were a lot of things with the data that gave us a lot of question marks that we had to work through. But.
Okay, thank you. Helen also has a question. Go ahead, Helen. I don't know if Helen's connecting with us by phone again. Helen? No? Okay, so perhaps Helen can put her question in the chat box. I will just check the chat box to see. No. Oh. Just a second. I'm just going to send Helen a note just to see. Okay. Well, we have to. Hopefully, Helen can send your. You know what? I hope that she sends her question through the chat box, and that you get a chance to see it later, Julie.
Sounds good. Yeah, thanks. Sorry for all the technical difficulties.
Oh no, it's okay. It's not your fault. We're all trying to do our best with what we've got here. So, and we're learning along the way for sure. So I appreciate it. Thank you so much for your excellent presentation. Such interesting work in Alberta.